Hello, my name is Stephen Rawlings. My pronouns are he, him. I'm an infectious disease doctor new to Maine and recently appointed the assistant medical director of the Gilman Clinic. And it's my pleasure to be presenting to you on new updates in HIV treatment guidelines for primary care. To start, I have no disclosures. I want to briefly mention the Gilman Clinic, located in Portland, Maine, and delivering excellent virology care since 1991. We treat HIV, hepatitis B, hepatitis C, as well as other liver diseases, and we offer an integrated approach to delivering care, and we're a site as well for clinical trials and novel therapeutics for people with HIV. The guidelines I'll be talking about are available online. In fact, just this little button right here for adult and adolescent ARVs. The clinical info network put out by the Department of Health and Human Services by the government has a lot of guidelines for various topics in HIV, but we felt the most pertinent thing would be reviewing the adult guidelines and changes that were recently made. You can download the whole guidelines. They start out looking like this. It's a long document. It runs 460 pages, but they have extensive notes and citations and comments. Really, the pertinent parts total to about 23 pages, starting off at the beginning. This is a living document. It's updated as deemed necessary by a panel of experts, and they did release a number of significant updates this past summer, which was part of the impetus for recording this update. Just wanted to highlight some of the very useful things when you do delve into the guidelines. There are some wonderful tables that can just be printed out and hung up in the clinic office. For instance, these tables show the different tests that should be done to monitor screening serologies, liver function, CBCs, things like that for patients with HIV, and the frequency, which is just really useful. The guidelines also highlight any changes that were made in recent versions. So before we delve into too much on the guidelines, just a couple of reminders and things to keep front of mind. For HIV testing, the CDC recommends HIV testing for anyone and everyone between the ages of 13 and 64 at least once as part of routine care. And so it doesn't have to necessarily be annual, but if it's a new patient to you, the CDC recommends obtaining an HIV test unless the patient says that they've recently had one. And just a reminder that the age 64 is actually probably not the border that we should be using here. You can still get HIV after the age of 65, and there are well-reported case outbreaks in retirement homes, so don't stick too hard and fast to these ages. The CDC goes on to say that if you're at high risk, and they have a listing of high risk available on their website, testing should be at least annual. And a comment about tests, most tests now are 4th generation tests. This is a combination of HIV antigen and antibody tests that allows for sort of a narrower window where a false negative could occur. So in other words, it can detect the presence or seroconversion of the virus much sooner. All preliminary positive tests on these platforms, both the HIV 4th generation and the prior 3rd generation, are confirmed with a Western blot. There are cases of false positives, and they can be stressful to patient and provider. And so that's a perfect opportunity to refer the patient to Gilman if you need any help. But it is possible to have a false positive, and it's just worth explaining that if you think the case is, the patient in front of you fits that case. The key updates that I'll be talking about are on the topics of what to start, the fact that as we get more and more ARVs deployed and ARV regimens deployed, we're finding very fine differences between regimens. And as those differences kind of become more clear, it's possible to separate out regimens into first line because of their side effect profile and overall tolerability. There were also updates to optimizing ART in well-controlled patients, the concept of changing antiretrovirals around if it's appropriate, as well as the use of long-acting agents, which were approved just this last year in 2021. And the panel also made guideline changes to options when a patient experiences virologic failure. And I'll talk about those as well. A few more housekeeping terms, just to go over terms and abbreviations. When I talk about ARV, this is the antiretroviral, which is directly the medicine. I'll sometimes talk about it in the plural, a combination of medicines. But the concept of treating with multiple medications together as a combination therapy is what we term ART, or antiretroviral therapy. We don't use the terms HART or CART anymore. HART was highly active antiretroviral therapy. An older term, combination antiretroviral therapy, also circulated for a while. But the concept now is that all of the therapy we offer is highly active. There's no need to distinguish it. Patients are either on ART or they are not. In case you haven't come across this, I think many people do know old abbreviations, things like PIs or NRTIs, but integrase inhibitors, which have been on the scene for a while now, do have an odd abbreviation, which is INSTI, for integrase strand transfer inhibitor. So you'll see me referring to those sometimes. And just a comment also about sort of community involvement. The HIV community is full of activists who really advocate for their own care. And among some of the changes they've sought recently are changes to abbreviations we use. So no longer do we say patients living with HIV. The community has advised that they prefer the term patients with HIV. And it comes down to just the concept, even though it's a single word, that living somehow implies there are other options besides living. And today, somebody who has HIV should be living a long and full life, and there's no need to call out the word living. That feeds into other concepts with HIV, and that frankly, the fact that there's still ongoing HIV stigma. Largely, this is rooted in fear as well as lack of information, and our jobs can be to help improve that information. Clinicians can help reinforce survivability and longevity for people with HIV. We can also address and assess our own biases and stigma, which may play out in the way we treat our patients. And I think it's really important to create a welcoming and inclusive environment so that people with HIV and their loved ones, or anyone that they know who might refer them to the clinic, sees that it's a clinic that's open and welcoming for patients with HIV. Just a couple of resources if this interests you or you want more information. Again, calling attention to the CDC website. They have this great website for HIV. It has basic information that patients can access, but they also have really nice printouts, the flyers that can be printed out and hung on the walls, social media campaigns that can just sort of help normalize HIV, decrease HIV stigma, and spread information that can be very useful to the community. Last but not least, before I get into the updates, I just want to again encourage linkage to care. This is a major thrust of CDC messaging. We know that linking people with HIV to care improves their treatment and improves their outcomes. So the benefits of treatment, and this should be emphasized to people with HIV, is that treatment means no progression to AIDS. It induces a survival similar to other mild chronic illnesses. I find myself a lot of times comparing living with HIV to diabetes. This is a case of another chronic illness that if a patient with diabetes takes their medicine, whether it be IV or oral, on a regular basis and has routine medical care, they can expect to live a long and full life. And the same can be said for HIV. Also, treatment reduces the risk of transmission to partners, and if anybody desires offspring, if they're of childbearing potential, reducing their HIV level and treating via treatment reduces the chance of transmission. And this is another major thrust of communication from the CDC based on extensive testing, large trials, that undetectable equals untransmittable, or U equals U, the concept that if somebody is fully virally suppressed, they have essentially no risk of transmitting HIV to someone that they engage sex with. So I'm going to start with the what to start updates that were put into the recent guidelines. As I mentioned, we're learning more and more about ARV regimens and can begin to create first-line regimens, or delineate first-line regimens. So the panel recommends that any new start of HIV antiretroviral therapy contain 2 nucleoside reverse transcriptase inhibitors, as well as 1 drug of another class. So that class can be an INSTI, an integrase inhibitor, a non-nucleoside reverse transcriptase inhibitor, or a protease inhibitor. So these are sort of considered the backbone therapy, and then the NTRI is adjunctive therapy. You'll see in the recommendations that all backbones, these in the first line, are actually integrase inhibitor based. So they say that this is their list of recommendations. They claim that it's all equal. They just listed in alphabetical order. So they include Biktarvy, a combination of bictegravir, tenofovir alafenamide, and emtricitabine. The combination Triumec, which is dolutegravir, abacavir, and lamivudine, and somebody trying to desiring to avoid tenofovir. Important to remember with abacavir that you must confirm that the patient does not have HLA-B5701, does not carry HLA-B5701, and they should also be without chronic hepatitis B because lamivudine is insufficient therapy for hepatitis B. Otherwise, any combination of dolutegravir as well as either emtricitabine or lamivudine or tenofovir alafenamide or tenofovir desafumarate, so TAF or TDF, is considered an adequate therapy. So this is 3 drugs. And essentially, you could see something like dolutegravir with emtricitabine and TAF, which is Descovy, or emtricitabine and TDF, which is Truvada, are options, or 3 medications by themselves. And then for the first time, the panel did endorse including a 2-drug regimen. This is Dovato, which is a combination, 1 pill of 2 medicines, dolutegravir and lamivudine. They do recognize and caution that the genotype testing should be back to confirm that there's no resistance to lamivudine, and the patient should not also be co-infected with hepatitis B. And lastly, it's not recommended for anybody who has a viral load over 500,000 when starting the medication. The panel emphasizes that there are lots of other options depending on individual factors and preferences besides those listed as frontline. There's no need to switch somebody to one of the one of the medication regimens that I just listed. If they're doing well on the regimen they're already on, they're just emphasizing that these are first line for starting therapies. There are issues that do remain for individuals who desire pregnancy. It's unclear how bictegravir could affect pregnancy, and so the panel continues to recommend not prescribing bictegravir to people who are pregnant due to insufficient data. There was for a while, a few years, where dolutegravir was recommended as was cautioned against in people who were pregnant due to suspected increased rates of neural tube defects in babies born to individuals using dolutegravir. But in large studies, namely the Sapano study in Botswana, the neural tube defects seem to be overstated and not related to dolutegravir. And so the panel now recommends that dolutegravir can be used, but a discussion of risks and benefits with individuals of childbearing potential should be undertaken. Moving on to optimizing ART in well-controlled patients, the panel specifically wanted to address the use of long-acting agents, which began in 2021. And so they start off by pointing out that advances in ART have made it possible to switch from one effective regimen to another. Gone are the days where there's one best regimen and anything else is potentially inferior. This would only be done if necessary from a clinical standpoint or if there was an overwhelming and strong desire. It is important that the clinician review prior regimens, the HBV serology, any toxicities or intolerances that the patient has had before to other antiretrovirals, and ideally any and all resistance assays that have been done before proceeding with a switch. And then the panel emphasizes that at least 2 active antiretrovirals are still needed. We don't believe monotherapy is acceptable. But there are some times when a medication combination pill might be desired, and one of the medications is known to be no longer effective due to resistance in the virus. If there are 2 active medications in that combination pill, it would still be acceptable to proceed. And then along these lines, the long-acting injectables, including Cabenuva, the only FDA-approved long-acting injectable single regimen for HIV currently. This is a combination of cabotegravir and rilpivirine. This would be an option in certain patients. The panel did endorse its use. And just a comment on this. If you have patients who are interested and want more information, we are obviously happy to provide that at Gilman Clinic. But just some background information. So this is Cabenuva is a long-acting injectable combination, as I said, of cabotegravir, which is an integrase inhibitor, and rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor. And it was improved as therapy for HIV in January of 2021. It's indicated as a complete regimen for the treatment of HIV in adults who are, and all of the following, so they have to have had sustained virologic suppression below 50 copies, ideally for at least 3 months, up to more is also acceptable. They should not have had a history of treatment failure, no known or suspected resistance to either of the components, cabotegravir or rilpivirine, ideally no HBV, hepatitis B co-infection, although they could still switch if they're willing to take an HBV suppressing medicine, and no other drug-drug interactions. There are few interactions to be aware of with cabotegravir in particular. The transition includes a 30-day lead-in with oral cabotegravir and rilpivirine just to ensure tolerability of the medication. And then the patients are given 2 injections, each of 3 milliliters, so rather large injections, as initial injections, and then every 4 weeks after that with maintenance, which is 2 doses of 2 milliliters each. In the studies, they do report high patient satisfaction, although authors also caution that there could be some selection bias because these were patients willing to enter a study of long-acting injectable. And there remain real concerns about how patients could be lost to follow-up, in particular because cabotegravir could have detectable levels in blood up to 12 months, and how that could impact resistance is still not clear. So it would need to be appropriately selected patients to ensure no loss to follow-up. The last update that I wanted to cover is options for virologic failure. So the panel defines virologic failure as an inability to achieve or maintain suppression of viral replication below 200 copies per ml. There are multiple definitions to be aware of in the guidelines for things like rebound versus blip versus low-level viremia. But the key point is that serial viral loads greater than 200 copies per ml likely indicate viral evolution and accumulation of drug resistance mutations, essentially because the virus continues to replicate under less than maximal suppression. It's important to recognize that there are multiple factors that lead to failure, virologic failure. These include patient or adherence-based factors, HIV-related factors, and ART-related factors. So it's important to assess all of these whenever encountering virologic failure before proceeding. Important for patient adherence factors, these can include cost, unstable housing, psychosocial factors, adverse drug effects, pill burden, or the frequency of dosing. That could all play a role in how frequently a patient's taking the medication and how effective it can be if not taken as prescribed. The virus itself could have transmitted or acquired drug resistance. There also could have been high viral loads. Certain medications are not indicated for high viral loads at initiation. And if there was a missed very elevated viral load for the regimen, perhaps the virus overcame some ART. And then from ART-related reasons for failure, things like suboptimal pharmacokinetics, certain medications require food to be consumed with the medication for optimal absorption, and other drug-drug interactions could lead to virologic failure. So assessing all of these factors is important before proceeding to attempt to change or correct virologic failure. One of the key points that the panel makes now, especially with sort of increased recognition that 2 drugs are sufficient, is that when responding to virologic failure, the new regimen should include at least 2 drugs that are expected to be fully active. And so here they define fully active as some uncompromised activity based on patients' prior ARV exposure. So an example would be dolutegravir or boosted darunavir in a patient previously on only reverse transcriptase inhibitor-based combinations. The panel says, the record goes on to discuss the fact that it's likely you're going to want to discontinue most, if not all, of the patient's prior regimen on the basis that it's probably all somewhat resistant. The virus has become resistant to most of it, and the lack of desire to continue medications that might have side effects without good effect. And then they do emphasize how important it is to perform resistance testing while the patient is on the failing regimen, with the idea that you want to sequence the most drug-resistant viral clones and analyze those for resistance. If a patient is stopped on their therapy and allowed to become more viremic before sequencing, the clone that gets sequenced may be a more virologically fit but less resistant clone. And we actually want to sequence the most drug-resistant clone. So performing genetic resistance testing while they're still on the medicine, the regimen that seems to have failed, is an important step. Other important features or recommendations to keep in mind. So it's important not to stop ART while awaiting decisions about a new regimen. Just because it's failing doesn't mean it's completely failed, particularly in somebody whose viral load is hovering around the 200s, 500s maybe, because they could rebound and be much more viremic and potentially experience a rapid drop in their CD4 count. So continue the regimen while working up and waiting for a new regimen. Also important to recognize that when switching off of a therapy, if it had anti-hepatitis B activity and the patient is co-infected with hepatitis B, if the new regimen does not have the same level of hepatitis B activity, it could lead to a hepatitis B flare. So keeping in mind that there might be other activities of the antiretrovirals that are being switched, and just want to keep an eye on those. I wanted to give a brief example just to sort of try to put into words and example what this could look like. So take, for instance, a patient who was taking Odefsey, which is a combination of rilpivirine, emtricitabine, and tenofovir alafenamide. Their viral load was persistently greater than 500 copies per ml after several months of taking the medication every other day because of cost issues. And so the clinician should send a genotype. It will probably show resistance at the levels to multiple non-nucleotide reverse transcriptase inhibitors and non-nucleotide reverse transcription inhibitors. And a possible regimen to start would be something like dolutegravir. This patient's been presumably naive to integrase inhibitors, if that's in fact the case. And then something like boosted darunavir. So now you would have a protease inhibitor and an integrase inhibitor. So two new medicines that meets the requirements of having two antiretrovirals, but they're presumably fully active. Another example could be doravirine, which is a rather novel non-nucleoside reverse transcriptase inhibitor, often very high barrier to resistance with doravirine. So something like dolutegravir or doravirine could be acceptable in this patient, especially if the genotype shows that doravirine is still sensitive. Just another plug that these patients, we would be happy to see them in our Gilman Clinic. We particularly happy to see complex cases, answer any questions, complicated drug-drug interactions. Those are our specialties, along with comprehensive HIV care. EPIC users can submit a referral directly to us using this reference code. Non-EPIC users can fax us a referral below. And I'm always happy to discuss questions. That's my email. I try to be quick in responding and would be happy to walk through anything. My last slides are just a plug and a reminder for pre-exposure prophylaxis, or PrEP. This is a daily medication taken for the prevention of HIV. The FDA has approved 2 oral medications that are currently available. These are Truvada, which is emtricitabine and tenofovir desofumarate, and Descovy, which is emtricitabine and tenofovir alafenamide. It is important to note that in the trials for Descovy, there were insufficient cis women in the trials, and therefore the approval does not cover cisgendered women. PrEP is very safe, very well tolerated. Important part to emphasize for patients who might consider it is that it's extremely effective, with greater than 90% efficacy at preventing HIV acquisition from sex. There is new medication that's potentially going to become available soon. Cabenuva by itself was approved as an every 8-week injection for pre-exposure prophylaxis. The drug name for this is Apretude, which is actually how it was approved under its drug name. More information is coming on that soon. We haven't proceduralized that yet. PrEP should be considered in anyone who has sex with someone who has HIV, especially if that person is viremic. Obviously, the messaging about U equals U still stands, but the thinking is that if somebody is engaged in sex with a partner who has HIV and wishes to have a bit of protection that they take into their own hands, they're not relying on their partner's ability to remain undetectable, they can take PrEP and feel that their margin of safety is dramatically increased. Anyone who has vaginal or anal sex and has not consistently used a condom is indicated for PrEP. Anyone who's been diagnosed with a sexually transmitted infection in the past 6 months, the thinking is if you've gotten one, let's prevent any others, or particularly let's prevent HIV. Anybody who has survival or transactional sex, that's somebody who may not have full control over the protection that they use during sex, and so adding on PrEP could be an important role for them. Anyone who injects drugs and shares needles or has an HIV injection partner, HIV positive injection partner, should be offered PrEP. Anyone who has had a prescription for post-exposure prophylaxis and continues that risk behavior, or anyone who's had multiple recent courses of post-exposure prophylaxis should also be indicated for PrEP. And effectively, one of the things I typically say is anybody who asks for PrEP essentially should have a discussion and should be offered PrEP. There are some fantastic guidelines and documents available through the AIDS Education Training Center program here. This is their link, the fabulous flyer that's just two-sided. It has basically everything you need, even this latest and updated cabotegravir apretude information. So I highly recommend going to them to check it out. And that is it. I just want to emphasize again that the Gilman Clinic is here to serve as a resource. We're hoping to record more of these videos, do more lectures, answer as many questions as we can. On the topics of things like PrEP, new ART as it becomes available, clinical trials even, we want to be doing all of it. I, again, am happy to answer any questions. This is my email. Please feel free to reach out. And I'm delighted you came here to listen, and I hope I can help in any small way improve the care being delivered to patients with HIV. Thank you very much.